Today, we start with the last chapter in this course, which is NCDs, non-communicable diseases. Okay, this chapter, NCD, and the previous chapter, CDs, and there is another chapter about environmental diseases. They are under one section in the book called Preventing the 3Ds, Preventing Disease, Disability, and Death. Okay, we already finished CDs. Now we go to NCDs. As you have had in the last chapter, CDs, there are three actual causes of the 3Ds. We call them determinants of disease. First, people die because of the following. Either they get CDs, communicable diseases, infectious diseases, or contagious diseases, like COVID-19, like vector-borne diseases, malaria, and so on, TB, AIDS, all of these diseases which have microorganism as the causative agent, and they can be transmitted from one person to another. Okay, or from one person to another, either directly or indirectly, to be quite precise with what I say. Okay, so first CDs, then we come to the most important, with the heaviest burden, is this, NCDs, non-communicable diseases, or some people they call it, or some books even, they call it chronic diseases, okay, because it has a long time span. Okay, and also we have the third one, which is the NED, or EDs, environmental diseases and injuries, diseases that are caused also from pollution of chemicals, wars. These are all environmental, ozone, global warming, all of these are environmental diseases. So a human being dies by either of these three, this or this or this, CDs, NCDs, and EDs. Let's see which of these here has the highest burden. First, we have to define what NCDs are. This is chapter 6, non-communicable diseases. This is the definition. What is NCD? In this book, they just try to avoid giving the name chronic diseases in this book. Some books, they still use this, but they say that the more professional name is the NCD rather than chronic diseases. So the definition of an NCD is that it's a non-infectious. So if you get cancer, you will not infect anybody else. If you get diabetes, the same story. These diseases are not contagious in anyhow, either directly or indirectly. Okay. Long term. So once you get the disease, it's going to take, maybe it's going to stay with you until you die. If you are lucky, just a couple of years. So it's usually long term, lifelong. We can say lifelong condition or disease, or adverse health effect, if you like to call it, due to degenerative. Degenerative means you are losing, yes, you are losing the function of your system or one of your systems. Deterioration, yes, continuous deterioration, that's degenerative, and there are degenerative diseases. Genetic, hereditary, both genetic and hereditary, they involve your DNA, your genome. So there is a mutation. There is something wrong with your genome, either shifting mutations or losing some. These are what we call mutations. And genetic and hereditary, you have this. In genetic, you might have it as a result of something that came from the environment, for instance, radiation or chemicals, something that happened to you during your life. Hereditary, from the mother to the children, from the parents to the offspring. But both of them, they involve a mutation and they involve your DNA. So every genetic is hereditary, but not vice versa. Okay. And environmental factors, as we said, we have many pollutants out there, particulate matters maybe, you have chemicals, you have the ozone, all of these pollution materials that cause problems. And unhealthy lifestyle. It looks that maybe you are very lazy to do exercise. We call it sedentary life. It might be you are addicted to fast food, the junk food, such as the food coming from McDonald's, coming from KFC, coming from Starbucks. All of these names, they sell you the unhealthy fast food, which can lead to NCDs. For instance, Starbucks failed in California to prove in front of the court that the coffee they make does not have a material that causes cancer, which is acrylamide. They failed to prove this. So for those of you who like Starbucks coffee, they have to stop because it has acrylamide, cancer causing. Anyhow, okay, that's just one example. So unhealthy lifestyle. Go back to nature, yes? Go back to nature, organic. And forget about all these big companies, yes, that make money on expense of your health. Okay, so no definite etiology. There is no cause. Not like CDs. CDs, we know that hepatitis B comes from hepatitis B virus. We know that AIDS comes from HIV. We know that malaria comes from Plasmodium. But here you cannot. Here there are what we call group associations, remember, which is association risk factor. So risk factors. Very rarely that risk factors are now developed to become cause. There is one sheer classical example, the smoking. Smoking as a risk factor became cause of lung cancer. But very rare that these risk factors, you have to work a lot on these to prove this. Smoking, they have worked a lot, and for decades, until they have proved that almost if you smoke, you are going to get lung cancer. So no definite etiology, but risk factors. Lead to impairment and disability or death, definitely. If you get diabetes, most probably you are going to get retinopathy if you don't control uncontrolled diabetes, uncontrolled DM, retinopathy, neuropathy, nephropathy, and impairment. If you get nephropathy, maybe it's not maybe. I have seen cases where it develops into renal failure. So you have to make renal dialysis. That's impairment. Okay. And after some time, it leads to diabetes, cardiovascular disease. You die. Or even from renal failure. Also, you die. Okay. So that's what it does on the long run, of course. These NCDs, they don't act very quickly, but they act on the long run. No spontaneous healing. You are not going to heal if you get diabetes. Definitely. Although there are some reports talking about if you change your lifestyle into healthy diet and exercise in the first, let's say, 3 to 5 years, you might revert back to normal remission in 30% of the cases. So still in 30% of the cases and in the beginning of the disease. But usually hypertension, CVD, cancer, you might get cancer, you might get rid of cancer after some very hard effort. So no spontaneous healing, rarely does it happen. Complete cure, also, that's what I say. Rarely does it happen. It might happen, but rarely. Okay, examples of these, we all know it. Diabetes mellitus, hypertension, cancer, renal diseases. Yes, some of them are CDs and some of them are NCDs, cystic fibrosis and disease. As we said, the risk factors. All the time we talk about the risk factors. Let's just show you the 9 risk factors that WHO puts forward as the most important. Let's go very quick to the WHO global report. This is the global report, global status report on non-communicable diseases 2010. Yes, this is the latest. This is the latest they can give us. Doesn't mean it's 15 years, but this is the latest they have. Let's go to the pages where I like to go. These are the risk factors. Let's go very quickly on these risk factors. First, modifiable, of course, those you can control, and non-modifiable, those you cannot control, like sex, for instance, or age. Tobacco, smoking comes number 1. 2, insufficient physical activity. You are inactive or inactive. Okay, so you lead sedentary life. All the time you stay at home, you don't go for walking. Alcohol drinking. You're addict to alcohol. okay, liver diseases, and so on. These are all risk factors. Unhealthy diet. Yes, you are eating junk food. The companies which we mentioned earlier, we don't have to mention them again. So be careful. Excel, yes, the Excel drink, also very nasty for health. Yes, devastating on your health. Don't use it. I'm saying this from the point of view of health, not anything else. Metabolic physiological risk factors, blood pressure, raised blood pressure. Okay, that's another risk. And overweight and obesity. If your BMI is more than 25, 30 and above, then you are obese, then most probably you're going to get CVDs and diabetes and all these NCDs. Raised cholesterol level. If you have higher cholesterol level, most probably heart disease and stroke. Okay. And these are the 9, yes, these are the 9 risk factors which, yes, additional modifiable risk factors of cancer. So these here, which were highlighted in yellow, I think there are 9 that WHO highlights as the major risk factors for NCDs. Okay, let's get back to the lecture. Yes, again, 7, maybe not 7. Okay, these are 7, not 9. But I mean, it doesn't mean that these are the only ones. I mean, these are the major ones. Yes. Okay. So anyhow, let's go back to the lecture. So these are the risk factors. Okay. If you look, we took this from WHO mainly. This is the NCD. We take this usually from the WHO, World Bank, credible sources. We never take things from just any website. No, credible website. Okay. So if you look here, you start down. This is number of millions, and here you can see that these diseases, and usually each year 55 million people die, or in that year 2019, 55 million people die. Out of these 55 million, 41 from NCDs. Can you imagine? 3/4, 75 almost 75% come from NCDs. That tells you how bad NCDs are, and the burden of NCDs. 41 million out of 55 million are NCDs. And you can go down from Parkinson, yes, homicide, killing, malaria. Malaria is usually a CD, yeah, but it's included here. Suicide, HIV or AIDS. This is CD, communicable disease, but maybe people consider it maybe sometimes NCD because of the complications and the period. Lengthy period. You can have disease for 20 years. But usually because it's a viral disease, they say it's a CD, and it can be transmitted from one person to another by blood transfusion or STD. Road injuries, kidney diseases, can be both, liver diseases, diarrheal disease, DM, diabetes mellitus, dementia, neonatal disorders, LRTIs, can be CDs and NCDs, okay? GIDs, gastrointestinal, RTDs, and most important is the first two. Why? Because they represent more than half of the cases. Look, 10 million people die from cancer. This is an NCD. And almost 19, let's say close to 20 million out of 55 by cardiovascular diseases. Because cardiovascular disease is something that is really branched. Many causes, many risk factors. If you can go to the 7 or 9, yes, seven risk factors we talked about, you will see all of them involved in cardiovascular, almost all of them. Smoking, alcohol, this, that, even smoking. So look, 54%, more than 50%, half of the number of cases come from these two here. And globally, this is according to WHO. So these data, we took them from WHO. They have the Health Observatory website, everything about health in the world. You can go there and just, they call it Global Health Observatory, I think. Okay, so globally, 55 million. Out of these, 41 NCDs. Talking about 3/4 of the cases. So, which is more severe to us and more serious, CDs or NCDs? NCDs. But which of them has, the biggest propaganda and CD, yes, COVID-19, they don't know that cancer is even worse. So the flash and the propaganda and people pay attention to more to CDs, not to NCDs. But look, NCDs are making the most of the damage. Yeah? CDs, it can't be CDs these here. Okay, impact and burden of NCDs. How do NCDs impact our life, quality of life? The first thing, I mean, some people are stubborn. They like to confront and combat and face and fight NCDs by making themselves, very stubborn, and they say, we don't want to stop smoking. We don't want to have a healthy diet. We don't want to do this. I'm just going to live my life. And just people who say this, just give them 5 years. They will see the difference. But they will see it when it's too late. Yeah, that's why you have to control NCDs. So quality of life. Life is important. And what's more important than life is the quality of your life. You are living up to 80. But which 80? 80 where people feed you, or 80 where you can walk in the afternoon alone? So this is the idea, quality of life. NCDs decrease quality of life, which means makes you closer to the 3Ds, disease, death, and disability. Then age. What is the relation? As we age, NCDs come to us. As we age, NCDs become closer. Because, our system, our DNA, our genome, it's not like when we are young. You will have lots of, let's say, mutation rate will increase. Your systems are not they don't function properly. Insulin, for instance, and from the pancreas, you will not secrete insulin if you are 50 or 60 in the way you were secreting it in your 20s. That's definite. Okay, so NCDs increase with age. So age, NCDs increase with age. Even diabetes type 2, when you are above 40 and you are obese, then it comes to you. Okay, so morbidity and mortality. You have seen that the deaths from CVD and cancer, they become very high, 10 million. So when you get NCDs, morbidity and mortality, you become, as soon as you are diagnosed, you are part of the club. Definitely. But the death will come later on. It depends on you. If you keep eating junk food, then you are closer to death. If you stay sedentary life, then you are closer to death. So death, morbidity from the time of diagnosis. Mortality depends on you. How you behave towards these. You want to live with them? You want to control these diseases? You can, and you can live happily ever after. Okay. Then economy. These diseases are very expensive to treat. Just have an example, the cancer. Can you imagine how much the cancer costs? That's why private insurance companies, they run away from such diseases. They tell you, go and make health insurance in the government, because they know it's costly. So the first thing they do when they try to get rid of you. And to be honest, the government provides the best treatment for cancers. But this is very costly. In millions, and in the world, millions and billions, maybe trillions. Can you imagine? Okay. So QOL, age, economy, and morbidity and mortality. These are the impacts and burden of NCD. In these 4 directions, it can affect us in these 4 directions. Maybe it will not affect you as an individual, the economic, but it will affect, yes, it will affect the health system. Okay, now, just exactly as we did in the CDs, here we have strategies to address the NCDs. 5 strategies to combat, to address, to control the NCDs. First, screening, testing, screening, early testing, intervention, treatment, counseling, and research. See, research, it might not pay directly, but research is very important. Again, screen, intervention, treatment, counseling, and research. Let's go to screening quickly. Screening. Strategy 1, screening. What do we mean by screening? Whom do we, yes? Early diagnosis. Very good. Why do we make early diagnosis? To minimize damage and to save people also. Exactly. Treating in the early stages is better than late stages. Very good. So all your answers are correct. Whom do we screen? Which people do we screen? Asymptomatic people. Or people, asymptomatic people, or I can say people at risk. Let's say, give an example. Breast cancer. Breast cancer. We go for women, or the risk group, we call it. This is the risk group. Do we go for men? No. Very rare. That's one. To minimize or to just to focus, to zoom on the risk group. Where do we go? Women above 35, 40. We don't go for young ladies like this. Maybe unless if they have, let's say, family history. So we go for only asymptomatic individuals, those people who apparently look healthy, but if you test them, they will give you positive tests. And usually these are the people at risk. Usually the people at risk. Women above 35, family history, then most probably we have to screen them. We don't screen for the whole population. Yes, sometimes it's very costly and maybe okay, and time consuming and maybe a waste of resources, who knows. Why do we screen? As you said, why do we screen? For early detection, to save the patient. Okay, so early detection, let's say for the cancer in general, we have 4 stages: stage 0, 1, 2, 3, and 4. If you detect the patient when he or she in stage 0 or 1, very likely he's going, maybe in stage 0 he's going to be completely cured, maybe completely cured. There's a high possibility. But if you detect the patient stage 4, very unlikely. Okay, so examples of these tests, we have very common examples which are practiced in our medicine in general. Breast cancer, we go for mammography. That's for screening. Very quick, not very much invasive. Also, some ladies, they say it's invasive, but not very much invasive compared to the other tests. Colon cancer, occult blood. You know what occult means? Exactly, hidden blood. Usually in the colon cancer, there is blood coming out because there is polyps on the sides, on the walls of the colon, and these polyps, they are scratched by the stool and then they bleed. At the beginning, you don't see the blood. Okay, so that's why you have to test for it. You don't see it, but in the test it's positive. But by the time you see the blood, then it's too late. Okay, so that's colon cancer. Cervical cancer, the pap smear for ladies. Cervical cancer. Why do we call it pap smear? Because of the stain, papinicular stain. And then prostatic cancer for men, for males. And we use this PSA, just PSA, prostatic specific antigen serum. You just take 2 ml centrifuge serum and then test it. Yes, there is a certain limit or range. Above this, then you are close to getting the cancer. All of these 4, as an example, these are sheer examples, let's say common examples. The screening test, if we get it positive, then do we say that the patient has the cancer or not? No, because this is just screening. We need confirmatory test, another test that is, so that's why we have 2, we call it sequential test or 2-stage test, sequential or 2-stage test. Either you have it quick, cheap, time saving, and not invasive. These are the screening. But if it's confirmatory, it's going to be time consuming, maybe expensive also it can be, invasive also it can be, and so on. Okay, but you don't make final decision of diagnosis from the screening. After screening, you go to another step, another stage. Okay, ideal screening program criteria. The criteria. When do we make screening? Do we screen for common cold? No, we don't have to, because it's something self-limited, and just we screen for diseases that are very severe and very serious and fatal, like cancers. Okay, that's one. So screening should be for fatal diseases, severe outcome. Okay, that's one. Secondly, early detection is possible and improves outcome, both of them. So some diseases, there is no early detection. By the time you find it, it's already too late. So why do we screen? It's a waste of time and effort. Some also, when you screen, you get positive, but maybe we don't have the treatment. So you are not going to improve the patient. The patient is going to die anyways. So if the detection does not, early detection does not make any difference, or you don't have treatment for this patient, then no need for screening. Okay. Third, feasible testing strategy. As I said, you have screening tests, and then example, let's say diabetes. What is the screening test? FBS, fasting blood sugar. You ask the patient to come after 12-hour fast and see if the patient is below 110 milligram per DL, then it's normal. If the patient is 130, 140, make another screening maybe. And in the 2 occasions or 3 occasions above 110, then you have to do a confirmatory test, second test. What do we call it? OGTT. OGTT, oral glucose tolerance test. You give the patient 100 grams of glucose, pure, not the table sugar, pure glucose. Some give the patient 75, but usually 100, and then test the patient on 0 time, 1, 2, and 3. And each time it has a normal range. If 2 out of the 4 are above normal range, then this patient is diabetic. Okay, so there is screening test, FBS, and there is confirmatory test, OGTT. Let's say breast cancer, mammography, then we have biopsy. You take a biopsy, and every test like this. Okay, so if the tests have this possibility, then it's good to screen. Because imagine if you don't have a confirmatory test, why do we screen? Because screening tests are not very sensitive, or maybe sensitive but not specific. Okay, acceptable. What do I mean by acceptable? It should be acceptable. It should be accessible. I mean, it's we have it in our system. Accessible, affordable. It should be we can buy it. Either you can buy it or it's in the Ministry of Health. The risk should be minimal. Patients should accept this, because sometimes the screening, sometimes, not all the time, the screening or sometimes it's invasive. Sometimes it's invasive, but usually the screens are not invasive. Okay, so it should be acceptable on those: the accessibility, affordability, patient acceptance, and the risk. There is no risk. Is there a risk to screen for blood pressure, hypertension? There is no risk. Why? Because it's only sphygmomanometer and you measure. Is there a risk here? No. So these four points, they have to be met before you say, I need to launch a screening campaign against this disease or that. Okay. As I said before, let's say breast cancer. Do we screen for it? Yes, because it's a common cause of death in women. Colon cancer, common cause of death in men and women also. So again, disease with high death rate or disability or fatality. We screen for these. We don't screen for simple diseases that are self-limited or just a few taps and they will go away. Okay. Criteria: early detection improves outcome. Have a look at this. These two questions. Is early detection possible? Will it improve the outcome if we find that the patient has this type of cancer? Can we save him or not? If we say yes on both, then you go for screening. Yes. If you say no, what happens? No need for screening. Sometimes you have this combination. Yes for the first, no for the second, or vice versa. In any of these cases, we call these lead time bias. In any of these cases, also, we don't go for screening. If we can screen and detect but cannot help the patient, no need for this. So screening only if you have yes answer to these two questions. Is early detection possible? Should be yes. Will it improve the outcome, the health of the patient? Should be yes. Any no or both no's, then you shouldn't do screening. Okay. Lung cancer, have this example. Lung cancer. Chest X-ray detects lung cancer very quickly, but the cure is too late. That's an example. Okay. We call this lead time bias. Okay. So feasible testing. Let's keep this for next lecture. Okay. Let's keep this for next lecture. Any questions? You have an exam now, yes? Wish you luck in the exam. It's not difficult.